Hello and welcome to Long COVID Foundation podcast. This is the channel where we share educational information on long COVID to help you understand your symptoms better. If you're new to the channel, make sure you hit subscribe button because I can help you get answers relevant to your symptoms. Now let's jump into our interview. Dr. Galland, thank you very much for being with us today. It's such a great honor to have you again on our channel.
Well, it's always a pleasure to talk with you, Valentina, and I'm excited about being able to share the perspective that I've gained in the treatment of patients with post-COVID syndromes.
I want to start this conversation by offering hope to those suffering from long COVID symptoms, sometimes for months or even years. So by the end of today's conversation, we are going to give people an education on how these symptoms can be managed naturally. And since the beginning of the pandemic, as you have mentioned, you have been deeply involved in studying the pathophysiology of COVID-19 with the goal of developing effective treatment for your patients. And through your dedicated work, you have created the so-called graphics that illustrate the interconnections between symptoms, pathology, and pathophysiology. And with that foundation, let's dive into our discussion on this particular topic.
Okay. So by the beginning of 2022, I had realized that what the research was showing indicated an interconnected set of alterations in the body that occurred as a result of having COVID-19. And so I created a graphic to try and describe that I call the web of long COVID. At the center of the web are two phenomenon that I think are very important when there is the acute COVID-19 infection and for some period of time afterwards. And that is a deficit of ACE2 and damage to mitochondria. And the two are very closely related. And they result from the interaction between the virus and especially its spike protein and our cells. So ACE2 is at this point well known as the protein on the surface of cells that the virus attaches to. And there's a particular part of the spike protein called the receptor binding domain, or RBD, that attaches to ACE2 and uses that attachment to get inside cells. Now, there are other ways that the virus can get into cells. The virus has other receptors, but for the majority of cells, ACE2 is the main receptor. My first thought when I discovered this, because this was the case for the original SARS virus 20 years ago, was, is there a good way to block ACE2 and prevent this from happening? Well, the problem with blocking ACE2 is that it's a vitally important enzyme. It regulates many, many functions in the body, blood flow and circulation and blood clotting and inflammation and scar formation, and recovery from all sorts of injuries. So simply blocking ACE2 is not desirable. And in fact, one of the effects of the virus entering cells is that ACE2 on the surface of the cells is destroyed. And it became very clear to researchers during the first year of the pandemic that many of the severe side effects of acute COVID were due to the loss of ACE2. And that led to an approach that I took to trying to treat acute COVID-19. And what I would say about that is, before the nature of long COVID had become obvious, I based my treatment for acute COVID on restoration of ACE2 activity. I believe it's as a result of this that hardly any of the patients that I've treated for acute COVID-19 from the start of their illness went on to develop any kind of long COVID or complications. I can't say none, but well under 1%. Whereas, in general population, it's probably 10 to 15%. So I do believe that restoring ACE2 activity is critical, and that an ACE2 deficit created by the infection, and sometimes even by the vaccines, because the spike protein itself can damage ACE2.
Let's stop here a little bit and just have some kind of recap before we continue into further discussing the whole web of long COVID that I've shown on the screen. So we have this variety of symptoms that people are experiencing, which are now formally attached to long COVID syndrome. But we try to get to the root of it. So mainly we understand now that it is due to ACE2 receptor, or maybe even more other receptors that viruses attaches to, and possibly even damages these receptors. And as you said, it leads to mitochondrial stress. And with only that, we already know that mitochondrial dysfunction is where all diseases start from, isn't it? So we know that type 2 diabetes, hypertension, cardiovascular diseases, dementia, fatty liver, all these diseases that we knew before long COVID start in the mitochondria due to insulin resistance and other issues that mitochondria is causing. So is this the cause that we need to address at the first instance in order to progress further to addressing those symptoms that people experience in long COVID?
Yes, I would say that is very close. Mitochondrial dysfunction is very closely tied to ACE2 deficit. That's been demonstrated in research done at the Cripps Institute in California. Mitochondrial dysfunction, independent of ACE2 deficit, occurs during COVID-19. And there was a recent study published in mice in which they were given COVID-19 in a laboratory, and they were given a cocktail to support mitochondrial function. And the support for mitochondrial function alone was enough to help the recovery from acute COVID-19. And now it's not, I would say in people who are already sick, it's not as simple as, okay, let's just support mitochondria. But that is something that makes a difference in the acute stage of COVID-19. Now, mitochondrial function is actually very complicated because mitochondria are involved in the body's antiviral immune responses. Mitochondria are the main source of free radicals being produced in the body under normal conditions, what are called reactive oxygen species, because that's where the fires that support our cellular activity take place. But that free radical activity can be damaging as well as beneficial, and it's getting the balance right that really matters. Also, in the face of COVID-19 or almost any viral infection, mitochondria kind of change their gears. They run differently, especially in the immune system. Maybe not in muscles. In muscles, it's, they're there supporting activity. The immune system relies on metabolism and mitochondria to run properly. It turns out that when you're mounting an aggressive immune attack, you actually downregulate mitochondria. There are other mechanisms of energy generation that are more useful to the cells when inflammation and infection is at its peak. However, for recovery, you need mitochondrial function. So with the onset of infection, mitochondria are kind of switched off. There's a pathway called aerobic glycolysis that's relied on, And there are a number of benefits, short-term benefits of that, but you have to be able to switch back and turn on mitochondrial function to recover. And even then, it's not a simple switch. It's not yes or no. There are pathways. But clearly, from my experience, a significant part of the problem leading to long COVID is that the mitochondria are damaged. And they can be damaged by the inflammation itself, by the ACE2 deficit and other changes that occur, but also just from the effects of the viral proteins themselves, which turn off genes that are responsible for mitochondrial function, that alter the dynamics of mitochondria. So that gets us into one of the very complicated parts of the web of long COVID, which I can get to whenever you want, which is this concept of viral persistence. In many ways, issues related to viral persistence are the most important in approaching a person who already has been sick for months or years. And the question that we need to answer is not only what did the virus do to this person's body, but is the virus still present in the body and in what form? And there are basically two types of viral persistence. And this does come back to mitochondria and ACE2. I mean, every part of this web is closely connected to every other part. That's why I thought a web was the best way to describe it. And even that diagram doesn't do justice to the interactions. But it was the best I could find on Google as a basis for creating the graphic. And it's
It
complicated.
already looks quite complex, especially when we know that all these processes run at the same time.
Yeah, everything is happening and everything is connected to everything else. But if you go to the West, if this were a map, or 9 o'clock, viral persistence is a really important strand. Now, viral persistence takes three forms. One is, and it's been very clearly described in multiple studies, that 2-3 years after having had COVID, with no infection or vaccination in between, you can still find remnants of the virus in tissues, especially in the gastrointestinal tract, which is the place where you can really look for it on a colonoscopy or a similar invasive procedure that's commonly done on people who, it's not like an autopsy or something. These are biopsies from colonoscopy that have shown this. The question is, are these remnants of the virus that are still present, or is this live virus that's replicating? And what we need to do is to find out a way to kill the virus. And it's really unclear. We don't have the tests to make that differentiation. I attempt to do it by making judgments from a variety of tests. But the fact is that the viral fragments can create just about as much inflammation as the live living virus. And one of the reasons I believe that these fragments of the virus persist is because of an effect that is due to mitochondrial dysfunction and ACE2 deficit, which is a deficiency in a vital function of the immune system for resolving inflammation that goes by the name of efferocytosis. Efferocytosis is a process by which immune cells, specifically large cells called macrophages — macrophage means a large cell that eats, basically — it's a process by which these cells gobble up and digest fragments of damaged cells, especially other white blood cells that have gobbled up the virus in the course of the infection. The failure of that leads to cell death, the release of proteins from the cells into the circulation, autoimmunity, all of the complications that we, not all of them, but many of the complications that we see in the post-COVID state or with long COVID can be explained by a failure of efferocytosis. And proper mitochondrial function and proper functioning of ACE2 are essential for this process of efferocytosis to take place. Now, I think that there are definitely people in whom the virus continues to live and replicate. And the question is where? And the most intriguing work in this area is the work that you first introduced me to from Carlo Brogna and his colleagues in Milan, who demonstrated that this virus has a rare capability. But let me just say that we should expect that the SARS-CoV-2 virus is going to do things that hardly any other virus does. And it will do multiple things that, maybe there are 2 or 3 other viruses known that do one thing and 1 or 2 that do something else. Well, this virus will do that and it'll do the other thing.
Seems like this virus has a project to accomplish, and depending on who you are and how healthy you are, the tasks will be different in everybody.
Right. If there's some form of mischief that a virus can create in the body, this virus knows how to do it.
Yes.
I mean, the spike protein has segments of amino acids, which are the building blocks of protein, that are very much like human proteins, way more than any other coronavirus does. I mean, it's kind of diabolical from that perspective. But getting back to the issue of efferocytosis, I'm sorry, getting back to the issue of the GI tract.
Yes.
So this virus has the ability not only to infect the cells of humans and other mammals, but also to enter bacteria. And viruses that enter bacteria are called bacteriophages. Now, their main function is that they destroy the bacteria. So they eat the bacteria, in essence. They eat it from within. Phage is the Greek word for eat. But bacteriophages can exist in different states within bacteria, and it may depend on the phage and the type of bacteria. Usually they're very specific. That is, a bacteriophage will infect strep, or it'll infect E. coli. It isn't exactly clear what the bacteria are that are infected by this virus, but what we know is that the species of bacteria that is in the GI tract of normal, healthy bacteria that is the most prone to phage infection is exactly the species that is diminished with COVID-19, which is a species called Faecalibacterium prausnitzi. That's not a well-known name. It should be, but it's a little hard to pronounce. This is what's called a keystone species. It really, it holds the architecture of the microbiome in the gut together. It's a major producer of a short-chain fatty acid called butyrate, which is essential not only for gut health, but for systemic health. Butyrate gets into the brain where it helps with restoration from injury. So this bacterial species plummets during acute COVID-19. It is also the bacterial species that is the most susceptible to phage attack. And we know that that butyrate, which is one of its main byproducts, plummets during COVID-19. So it's very likely that that's at least one of the places where living virus can remain in the body, and then it can come out, it can get into your cells.
Yes, so just to add here, we previously had an interview with Dr. Carlo Bronia, where we discussed some of his recent publications on bacteriophage behavior, and Carlo is trying to identify particular species which are infected. And as you said, it's hard to do, but looking to species which are low on the stool samples, it's again, quite often it is Akkermansia as well, and Lactobacillus and Bifidobacteria are all at low range. So it might be a possibility that those species are infected too.
They may. So bifidobacteria depends upon Faeculum bacterium prausnitzii, because the butyrate produced by the F. prausnitzii is the main food of the bifidobacterium. So I think they're very closely related.
Yes, right.
It may be a little bit different for lactobacilli. Lactobacilli, although they are such important probiotics and have major effects on the GI tract, are not generally dominant organisms in the gut microbiome. However, there is a study from Mexico using a probiotic mixture of lactobacilli primarily, from my favorite species of lactobacilli called plantarum, which is found in fermented foods.
Yes.
But with this particular probiotic, they found that they were able to shorten the duration of acute COVID-19 in a double-blind placebo-controlled trial, and also to decrease the viral carriage, the amount of virus in the body. So I think lactobacilli do play a very important role, and that's another part of the web right next to viral persistence, which is microbial dysbiosis. That is, there's a disruption and a major disruption.
If you allow, talking here on the trillions of bacteria that live on us and which have an immense effect on our immune system, and these very bacteria influence who we are and how strong we are. So by consuming a nutrient deficient diet that is rich in harmful sugars and GMO foods, we risk this, for example, dysbiosis of the gut and metabolic issues and the whole host of chronic diseases, and can be linked to long COVID as well. So how, in your opinion, important healthy diet is, and deficiencies that were caused due to poor diets before long COVID, and we still have this happening?
That's a very important question, Valentina, and it's related. ACE2, mitochondrial function, gut dysbiosis. They are all very closely related, and if you just take those three strands of the web, those three parts, they all are greatly influenced by diet and lifestyle. And so what is the kind of diet that most supports ACE2 activity and a healthy gut microbiome? It's the same. It's a nutritionally dense, high fiber, largely plant-based diet, rich not only in the usual nutrients, but in nutrients called polyphenols, which include bioflavonoids and other chemicals. And polyphenol-rich diets increase ACE2 activity. They also act like curators of the microbiome to encourage the growth of the species that we most need to promote health and to keep the intestine well sealed, so you don't develop this phenomenon called leaky gut, which is another complication of COVID-19. As soon as you start disrupting the healthy microbiome, the GI tract starts to become leaky. So now, in addition to whatever problem you had to begin with, you have this leaky gut phenomenon in which toxic substances and maybe bacterial byproducts and fragments and viral fragments that are inside the gut are getting into the body, into the systemic circulation. Whereas in a state of health, they're confined to the inside of the intestinal tract. So that is absolutely critical and a real mainstay of treatment. And one of the reasons why acute COVID-19 seems to get worse with age is probably because as people get older, their microbiome suffers under the impact of kind of the modern lifestyle. Healthy centenarians have a gut microbiome that's very similar to people in their 30s and 40s. But there aren't too many healthy centenarians around.
Absolutely.
So the composition of the gut microbiome impacts the risk of heart disease, stroke, diabetes, obesity, autoimmune diseases, all factors that are risk factors for the severity of acute COVID or for the development of long COVID. And from a preventive perspective, diet and the right kind of diet, the one that I've just described, and regular, especially aerobic exercise, probably the best things that a person can do to tone their body to resist long COVID or severe COVID. Now, if you already have COVID-19, we move into a different playing field. It depends on how long you've had it, how sick you are, what your symptoms are. But there is no circumstance under which a typical Western diet, high in added fat and added sugar and low in fiber and low in polyphenols and other nutrients, is going to help you recover. And it is most likely that it will interfere with your recovery, whatever your specific nutritional needs may be.
Thank you very much. This is a very important point because the clients I'm seeing now, they first need to understand that long COVID is not treated by a single treatment protocol or just, taking Nattokinase for spike detox and they will be fine. No, we first need to address the metabolic health and dysbiosis if it has been developed through long COVID, especially when people are suffering for years. I think they first need to look into nutrition field before they jump on any treatments.
Yes, nutrition and lifestyle. That is, you need sleep, and you need to be very aware of your body. If you've been sick with this illness, you need to know how to manage your body. And in fact, I've seen so many patients who, by the time they come to me, say, well, it's not as if I've really solved this problem, but I'm living my life much better because I know how to manage it. So self-management is really critical now, my view on this is if you want to live in the world, self-management is the most important skill you can learn. This isn't just for people who have had COVID. Everybody should know how to manage their bodies, how to manage their lives. That should be taught in school. It isn't, but it is especially important if you have a chronic disease, and especially with this chronic disease. One of the things that has been most striking to me about patients with long COVID, with the chronic fatigue, ME, presentation of long COVID, is the severity of what's called post-exercise malaise or post-exertional symptom exacerbation. Post-exertional malaise really doesn't capture what can happen to a person. And symptom exacerbation is broad enough that we can accept that, PESE, P-E-S-E. What is striking is not only how severe it can be, how little exertion it takes, but how for many people, mental exertion can be as bad or worse than physical exertion. That is just trying to use your brain more than for a few minutes can leave some people taking days and days to recover. That's not something I've seen before. I mean, I've been treating patients with CFS and ME for 45 years now, at least. And this phenomenon of peace has always been part of it, but never as debilitating and restricting as I've seen with the post-COVID patients, and never really impacting cognitive function to the same extent.
And this is very important point that you mentioned, because quite many conferences that are run on long COVID and many practitioners who try to treat long COVID patients, they somehow connect long COVID to an ECSF, and they state, oh, we are treating long COVID for 20 years, we've been treating that. So it's exactly the same thing, and we know how to do that. No, this is a new disease.
This has so many distinct features. Now, if you look, first of all, ME/CFS is a very mixed, heterogeneous group of disorders. And if you look at the people who have it, I mean, that diagnosis is made. That's not something, you don't make the diagnosis of ME/CFS when you get acute mononucleosis. It's made years later, and then you look back and say, oh, well, since I had mono, I never recovered, or since I had this problem, I never recovered. It's here we're looking at it in real time, prospectively, from the acute infection to the outcome. And the best study on ME/CFS, there are two good studies that were done that kind of looked at what we'll call epidemiology. One was done in Australia back in the 90s. It was in a small town outside Sydney. They just followed everybody in that town who had Epstein-Barr virus infection, which would be mono, Ross River virus, something that occurs in Australia and is known to lead to chronic fatigue, or Q fever, a bacterial infection, mostly occurs in Africa and to some extent in Australia, although veterinarians or people who deal with animal skins can get it. And what they found was that 6 months after the infection, 12% of people with any of those infections were still suffering from fatigue or brain fog, kind of a CFS-ME type of picture. They didn't follow them longer. But here's what's really important. They found that the likelihood that someone would have this condition was directly related to the severity of the initial illness. Now, we all know that there are a lot of people who have very mild COVID-19 and become debilitated 2 months later when something else happens to them. This is a different picture. There was also a study done in Scotland that also in the 90s that was a population-based cross-sectional study of the frequency of CFS-ME in the population. And what was very interesting was, it was under 1% of the population had it. There was no gender or sex-related effect. That is, it was equal in males and females. every study has shown that there is a predominance of long COVID in women, about 2 to 1 at least. What this suggests to me is that there's a role for autoimmunity in this, because, I mean, we all know that most autoimmune diseases are 2 to 3 times more likely to occur in women as in men. And that has something to do with hormones and the impact of hormones on the immune system. And so one of the actually autoantibodies and T cell dysfunction are two strands in the web of long COVID directly related to the phenomenon of autoimmunity. Two of the strands of the web of long COVID involve production of autoantibodies and impairment of T cell function. Those are all critical components of autoimmunity. And I do believe that autoimmunity plays a role in the occurrence of long COVID. And a deficit of ACE2 imbalances immune responses in a direction that would favor autoimmunity. Diet also has an effect on autoimmunity, but it starts to get very complicated. Because, well, if we just take T cell function, for example, what's been shown is that there are numerous deficits of T cell function that occur, T lymphocytes, which are an important part of the immune system, that occur during and after COVID-19. I haven't seen any compelling evidence that there's just one pattern. There seem to be many patterns. What we do know is that fermented foods enhance the activity of T cells, and T cell activity is very much influenced by a healthy gut microbiome. So on either side of viral persistence, you have T cell impairment and microbial dysbiosis. They both contribute to viral persistence. They're both very much influenced by diet. Autoantibodies are more complicated. Many have been described in the course of COVID and long COVID. Their exact functions at this point are not really clear. I think anyone has really come up with a generally available, effective therapy for dealing with the autoantibodies. We will, but dealing with the other strands of the web is likely to help, because what is driving autoantibodies is the immune system's response to damaged tissue. And so if you can begin to clear up the tissue and restore efferocytosis, which requires restoring ACE2 activity and mitochondrial function, then you should be able to start clearing the autoantibodies over time. Sometimes when there is an autoimmune component, the way that a person will respond to diet is not the same as the way other people will respond to diet. And so for people with autoimmunity, the dietary recipe for treatment, not so much for prevention, but for treatment, may need to be altered. A lot of people benefit from, let's say, a gluten-free diet, or a diet that's free of gluten and casein. Casein is a protein in milk that's very similar in its physiological and immunological effects to gluten. And over the years, I found that many people with autoimmune disorders have benefited from a casein and gluten-free diet. And I think it's because of the negative impact of the proteins in milk and wheat on immune function in people who are susceptible.
And does it come again back to microbial dysbiosis and infected bacteria and all the coming back again to what we have discussed previously?
Yes, it may go back, especially to the gut dysbiosis, because the classic example of gluten intolerance is celiac disease. That's an inherited genetic disorder of the immune system. Well, it turns out that bifidobacteria protect against celiac disease, even in people who are genetically predisposed to it, because bifidobacteria actually metabolize the gluten in ways that make it less dangerous and less likely to provoke an abnormal immune response. So yes, in a way, every part of the web is connected to every other part, but the gut dysbiosis is a really critical component for immune function.
Great, thank you. So let's move then. 3 o'clock for the diagram is monocyte polarization. What it is?
Okay, yeah, that actually that name is too short. It's really monocyte and macrophage polarization. And monocytes and macrophages are related cells. They're related to the extent that monocytes can turn into macrophages, but not all macrophages start as monocytes.
Okay.
They're a part of the immune system called the innate immune system. It means you're born with them fully active. They don't have to get trained the way that lymphocytes have to get trained to respond. And they are and so monocytes circulate in the blood. When they enter into tissues, when they leave the bloodstream and go into tissues, they become a type of macrophage. And monocytes and macrophages have complex life cycles with 3 basic functions. This may be a little more than you want to know, but I think it's important to understand it, to understand polarization. Those functions are attack, repair, resolve. And the monocytes, instead of resolve, it's patrol. So they're basically looking for enemies, okay? So they patrol looking for them. If they see them, they attack them, and then they start to repair the damage that's been done, because the attack is very damaging. I mean, there's a lot of damage to your own tissues. Macrophages are not so much patrolling, they're not circulating, but they are involved in attack. These are the so-called M1 macrophages. They then mature after the attack into M2 macrophages that are involved in repair processes. Efferocytosis requires that they then further mature into what are called M-res macrophages. And it is that process by which circulating monocytes turn into macrophages, and macrophages go through their life cycle that is very much dependent on ACE2 activity. Because the end product of ACE2 activity, a hormone called angiotensin 1-7, shepherds that whole process. And I think it's really screwed up with COVID-19. So I will go into the protocol that I recommend for dealing with ACE2, which is, as I said before, this is going to be most effective early on, at the time of infection, soon after. Once you get down the road, there's a lot of tissue damage. There are many other things that need to be done. And yes, you do need to go back and repair ACE2, but the horse is out of the barn by that point. And, there's a lot more that needs to be done. So what happens is that the monocytes and the macrophages get stuck. That's the way they polarize. They don't go through their full life cycle in the way that they are born to do. And that's, I think, a result of the ACE2 deficit, but there may be other factors as well. And that's been pretty well documented that occurs. But it's not as if there's a treatment for that other than this idea of improving mitochondrial function and ACE2 activity. And the ultimate goal is to move them through their life cycles So you get to that stage of resolving inflammation and efferocytosis. Now, right next to them is an area that I think is critically important. If we go up to the northeast part of the web, which is mast cell activation. Mast cells, like macrophages and monocytes, are, or like the macrophages in particular, these are cells that don't really circulate in blood. They're in the tissue. They're kind of loosely scattered in the tissue. There are not too many of them. They're very primitive. In the history of the evolution of animals, they appeared before any of these other immune cells appeared. And actually, that's directly east. It's not northeast. We'll get to northeast in a minute. Mast cells are best known because of their involvement in allergic reactions. They're these large cells that release about 200 different chemicals when they get activated. The best known is histamine, which is what causes many of the symptoms of an acute allergic reaction. But mast cells become involved in any kind of inflammation. They don't only respond as part of an allergic reaction. And of course, all of these cells, even though they may make you sick, they're there to kill your enemies. Mast cells are particularly good at getting rid of parasites, but especially in a situation where you're not dealing with parasites all the time, mast cell activation might start to become dysfunctional. One of the fascinating things about mast cells is they're quite sensitive to electromagnetic fields. And there was a study done at the Karolinska Institute in Sweden. That's the place that hands out the Nobel Prize. So it's not a lightweight institution. They put people in front of a TV monitor and they did skin biopsies. And they found that for before and 2 hours after watching television, it's kind of amazing. In about 25% of those people, there were changes in the mast cells that they attributed to the EMF exposure from the TV monitor. They were sort of migrating more towards the surface of the skin, or they were actually, in some cases, releasing their ingredients that they have, some of these chemicals that they have stored in granules. Mm-hmm. Mast cell activation has gotten a lot of attention over the past decade. That started even before the pandemic, but the recognition that it is important for many people who suffer from long COVID, I think, has enhanced that. But I think we're seeing an absolute increase in people with mast cell problems because of widespread EMF pollution.
Is it somehow related to the allergies that people may have had before, something that they develop further on into mast cell activation?
There definitely are genetic factors that make people more prone to mast cell activation. Having allergies is one, but there are people who don't have classic allergic problems who are also prone to it through other mechanisms. Some of these can be measured in blood, tryptase, for example. And there are a number of different disorders of mast cell activation. Some involve an increase in the number of mast cells or changes in the types of mast cells, and others involve no change in number or type. They're just trigger happy. They're just more likely to release their chemicals. They're not stable. Two questions. One, to what extent is mast cell activation part of this person's problem? If their post-COVID problem? And what can you do to stabilize the mast cells? And this is also, there is no part of this that is simple. There's just nothing that's simple about COVID. I mean, there are many things. Fortunately, in the lack of simplicity, there are a lot of therapeutic choices. If you really take the time and put in the effort to look at all of the factors that are influencing what's happened to a person since having COVID, there are a lot of treatment possibilities. There's not one single treatment. There are many treatments. And what I find I have to do in my practice, but this was even true before the pandemic, is I have to individualize treatments based on the characteristics of the person. Now, I created a document on my website to try and help people do this for themselves. Let me just say that mast cells are activated during acute COVID-19. A lot of the damage in the lungs with COVID is due to mast cell activation there. Mast cells also interact with a couple of the other strands I'm going to get to, the microthromboses and the endothelial inflammation, or the blood vessel inflammation. But they play an important role in acute COVID. And the question becomes, is this person able to turn them off and return them to their pre-COVID state or not? And the inability to do that may have genetic influences. Now, how do you know if that might be part of the problem? And by the way, if this is a major part of the problem, it can become the 800-pound gorilla in the room. You have to deal with this. You won't be able to deal with anything else until you get this under control. Because what they do, it so disturbs your biology and physiology. Okay, first of all, do you have any symptoms that sound allergic or seem allergic? Swelling, redness, itching, coughing, wheezing, headaches. Mast cells play a role in migraine headaches. They can play a role in joint pain or in GI symptoms like diarrhea. Secondly, do you have unexpected or unusual adverse reactions to treatments that everyone should be able to take? Like you take an aspirin and and something bad happens to you. The people who cannot take vitamin or mineral supplements or most medications, they likely have a mast cell component. Are you very sensitive to what's happening in your environment? I'd mentioned electromagnetic fields, but just temperature, pressure, things like that. There's likely to be a mast cell component to the way that you're responding. The treatments for mast cell activation have actually been pretty well studied, some of them, in the course of long COVID. And they break down into two types. One, the most commonly used, are those treatments that block the effects of chemicals released by mast cells. And they start with antihistamines, which for some people have a major impact on the way that they recover. And there are these case reports of people with POTS, a condition in which you have a hard time standing and walking because your heart races, responding to antihistamines. Now, I personally haven't seen that, but there are published case reports on it. So I think it's worthwhile to explore how your body responds to the standard over-the-counter antihistamines that you can get in any pharmacy. Then there are the second group of antihistamines, which are not known by that name. They're used for reducing acid. They're called H2 blockers. One of the effects of histamine in the stomach is to promote the secretion of acid. And that's through a different mechanism than the allergic reactions. It's through a receptor called histamine 2 or H2. And that is blocked by drugs like famotidine. In the US, it's called Pepcid. That's the easiest to get these days of the H2 blockers. And there was a study that was done, I forget where, somewhere in Europe, where people with fatigue and brain fog post-COVID were given famotidine. at a dose of 40 milligrams twice a day for 3 months. And this was a placebo-controlled randomized trial. There was a significant improvement in cognitive function with the famotidine, making it likely, it's never 100% proof, that the effects of histamine in the brain may contribute to brain fog through this H2 receptor. Those are the things that you can do in terms of over-the-counter drugs. Aspirin may block some of the effects of mast cell activation, and so do the other non-steroidal anti-inflammatories like ibuprofen, for example. And understanding how your body responds to these, especially if you're in this state where you seem to be very hyperreactive to so many things, and have paradoxical reactions to treatments that should help you, that can be very helpful in determining the direction to go in. I have people writing me every day from around the world saying, I've been sick for 2 or 3 years. And if they share their symptoms with me or what's happened to them, and I read all of the emails and I try to respond to them. It's not so easy, but I know that, people are really suffering, and it's very hard. It's just very hard to get useful, practical information. I would say that 2/3 to 3/4 of the people that write to me, it's clear from their description of their problems that they have mast cell activation problems that have developed or gotten worse as a result of COVID-19. So I have a section devoted to that in the document on my website, and there are links to some very useful references. Despite that, there are doctors around the world, including specialists, who say, "Oh, there is no such thing as mast cell activation."
Yes.
Which is an
It's
absurd
very
statement.
sad. Yeah, very sad to hear about that. So that people are not addressing mast cells, and they're not even testing. They don't want to prescribe any tests to people to identify.
Right. Well, the tests are only accurate about 30 to 40% of the time under the best of circumstances.
Mm-hmm.
So what the tests are very good at doing is identifying conditions that are where there's a proliferation of excess mast cells, or where there's some other genetic type of disorder that may be creating this mast cell activation. It's important to know about, of course. In terms of things that the things you can do yourself if you have mast cell activation problems, we'll start with diet. With this problem, a healthy diet may not work for you.
Exactly. This
And the
is what I
diet,
wanted to ask, because we always talk about probiotics and kimchi and sauerkraut and kefir and all these kind of things, which are not allowed to people with MCAS issues.
well, you may not tolerate them. Now, I
Yeah.
think it's important to recognize that there are two parallel conditions that are
Mhm.
not the same. One is mast cell activation, and the other is histamine intolerance. Histamine intolerance is not mast cell activation. It is an intolerance for histamine produced in the GI tract. And it is basically due to a leaky gut and inflammation in the gut. The inflammation in the gut, so of course, this is not uncommon after COVID. Inflammation and leakiness in the gut does two things. It disables an enzyme called DAO, or diamine oxidase, which breaks down histamine. It also allows a greater absorption of histamine into the body than would ordinarily occur. Amines like histamine are not all that well absorbed normally. And then there are certain types of bacteria that may be more likely to produce histamine. Probiotics that might be helpful for somebody else can aggravate histamine intolerance. But Mast cell activation is really a systemic problem. Histamine intolerance starts in the GI tract. There are diets, you can find them online, low histamine diets. If you are aware that food seems to negatively affect you, that's a pretty good place to start. Does a histamine restricted diet work for you, or doesn't it? Most of the patients I've seen over the years with mast cell intolerance, mast cell activation, are not histamine intolerant, by the way. They don't need to follow a low histamine diet. So that's a diet that if you don't need it, may be overly restrictive and not even healthy. But you do want to be aware of how food and meals impact your symptoms. This is going to take a number of explorations on your part. I published a book about 8 years ago called The Allergy Solution. I don't really deal with mast cell activation in that book. That would be like you'd need a whole separate book for that. But I do have an approach to evaluating food allergies in there that I call the power wash. It was designed to be done during a long weekend to be nutritionally adequate, to use common foods that were not likely to cause allergies. Of course, with mast cell activation, anything can trigger them, but an approach like that may help you determine how much of an effect does my diet have on my symptoms at this time. And then there are a number of natural products that can help stabilize mast cells. Their work goes beyond just blocking histamine or other mast cell chemicals, but actually stabilizing the mast cells themselves. Quercetin is at the top of that list. It's a bioflavonoid. It's normally found in apples and onions and a number of other foods. It's available as a supplement. Many people benefit from taking high doses of quercetin. And there was a study done early in the pandemic, a couple of studies that showed that taking quercetin decreased the risk of acquiring COVID if you were a healthcare worker. Other supplements are listed in this document that I created. Now, going around to the north part of the web is a very important area of two things that are related to one another and that clearly happen with acute COVID and appear to contribute in many people to long COVID, which is microscopic blood clots, that's microthrombosis, and something that I describe as endothelitis. In the UK, it's endotheliitis, and in Australia and South Africa, it's endothelialitis. This is inflammation of the lining of blood vessels. In fact, that is something that happens immediately with COVID-19, and it also happens with vaccination. A colleague of mine in New York City, a dermatopathologist, did skin biopsies on herself and her colleagues after they had received the Pfizer mRNA vaccine, and they had no symptoms. And she took biopsies from near where the vaccine had been administered in skin that looked totally normal. And she was able to demonstrate that the spike protein from the vaccine had attached to the lining of blood vessels in the skin, and where it attached, there was inflammation. A protein called interleukin-6 was present in elevated numbers. So this phenomenon of endothelial inflammation is an essential intrinsic part of COVID-19. It happens to everybody, and it happens even with spike protein-based vaccines, because it is the spike protein that is attaching to the lining of blood vessels.
Okay, so does it mean that the spike gets to the cell and then creates the senescent cell? So the cell becomes senescent and it creates inflammation further on the lining, on the organs, and it doesn't flow, it just attaches to the cell.
Okay, so senescence does occur, but this is even before this is like early. This is
Right.
before senescence. This is maybe one of the things that drives the senescence. And by the way, ACE2 is a senolytic enzyme. Okay.
Okay.
Its byproduct, angiotensin 1,7, reverses cellular senescence. So the loss of ACE2 plays an important role in this, just in cellular senescence, which is one of the unfortunate complications of COVID-19. But just getting back to initial events and the role of inflammation, people who already have damaged blood vessels, they're the ones who are most susceptible to this. Studies were done in a test tube or in a petri dish where they looked at the effect. They took human blood vessels and they tried to infect them with the virus. And they found that healthy young blood vessels, they would get infected with the virus, but they would clear the viral infection within a day or two, and there'd be no damage left. This was done in tissue culture, so they created senescence of the blood vessels by running the cells through, keep recirculating the cells. They would harvest the cells and plate them again, and harvest them and plate them again. And after about 3 or 4 passes, they now had senescent cells. That's what happens with tissue culture. You start out with brand new young cells, but if you keep taking those same cells and replating them, they begin to become senescent. Those cells could be infected and the virus would remain. And it was what they call productive infection, in that the virus stayed there and it continued to damage the cells. So there is, in answer to your question, yes, cells that are senescent are more susceptible to these effects, at least in blood vessels. What this does in the blood vessels is it creates an environment that favors blood clots. Ordinarily, under normal conditions, your blood vessels are designed or have evolved not to discourage blood clotting so that everything flows. But as the cells get inflamed, the whole environment of the cell surface changes, and now blood clotting is encouraged. So you get this combination, this really dangerous combination of inflammation of the lining of blood vessels and microscopic blood clots. And it's a feed-forward loop, because the microscopic blood clots increase the inflammation of the blood vessels, because they involve the activation of platelets, blood platelets, which are then inflammatory. And mast cells play a role in this, and so do monocytes. Everything on the right side of that web, or the east side, is related to one another in this feed-forward fashion. Because all of those cells get engaged in the process of increasing inflammation and increasing blood clotting. And it's a never-ending feed-forward process unless something happens to stop it.
Something that works to stop this. We know that nattokinase is now being highly recommended for breaking down this microclots. Is it really safe to use nattokinase?
That is a very good question. There are a lot of people who say that nattokinase has helped them. It's helped their symptoms. Nattokinase by itself is not likely to break down microclots. And it's really uncertain whether the ability of nattokinase to break down spike protein is really something that happens. I mean, the nattokinase isn't getting inside the cells.
Exactly. So
this is what I
wanted to, maybe you could elaborate a little bit on the process, on how the ideal detox, spike detox should work in terms of breaking down the cell, releasing the spike from the cell, and then attaching to the spike, only to the spike protein, not other proteins, only on the spike protein, and removing it, making the cell death or renewal of a cell. So what is the that very intriguing mechanism
Right.
behind
Well,
spike.
right. Okay, that's an excellent question. I think the research is still ongoing. That is, we don't know all the details of that. Um, our friend and colleague, Joachim Gerlach and his team have been researching this intensely. I hope to have his protocol available very soon. I've been waiting for it and waiting for it so that I can see how well what works in the laboratory works
Yes.
in my
There is
patients.
a hope. There is hope.
Yes. Yeah. Oh, there definitely is hope. And um, one of the mainstays of that, aside from the medicinals mixture, which has it has anti-senescence effects just because of its components and antiviral activity. So that's very helpful. The fucoidan, which comes from seaweed, is something that is a part of that protocol. Now, seaweed is very helpful in a number of ways. Fucoidan previously has been shown to boost immune responses, to stimulate T lymphocytes. It binds specifically to the spike protein, but you have to get the spike protein out of the cell. I mean,
Yes,
the
yes,
fucoidan
that's a
isn't.
very, very difficult task. And I am always very cautious when people are saying that nattokinase is the only solution for that, and which is not, and there is not much research that nattokinase attaches to the spike and breaks that particular
Right.
effective cell out.
There's one study. There's one study that showed it could do that in a test tube. We don't know that it's happening in real life. Risa Pretorius in South Africa, who really pioneered the work on the microclots, she has said that the combination, and she's not a physician, she's not treating people, but she has said that the combination of nattokinase with aspirin, not a nattokinase alone, that many of her colleagues have found that's been helpful. So I know that I have some colleagues who are very weary of nattokinase because of a concern that it will break down the spike protein in a way that will release more toxic fragments into the body. I think we need an awareness of that as we try to move forward. The nattokinase does some other things, by the way. It calms the sympathetic nervous system.
Yes, for a healthy person without spike, maybe
yes,
it's an
for healthy people,
yes.
nattokinase does a lot of good things. I don't think the ultimate spike protein detox has arrived. I do think, but I'm very excited about being able to employ the medicinals protocol in the near future. I do want to get back to efferocytosis and ACE2 to try and answer this question about eliminating spike protein. However, this is what enhances ACE2 and then enables efferocytosis. And macrophages do play a very important role in clearing spike protein out of tissues. Aside from the kind of diet that I've talked about earlier, a polyphenol-rich diet, vitamin D is important for ACE2 activity. Not toxic amounts, adequate amounts. A lot of people don't have adequate vitamin D, especially outside the summer in northern latitudes. The curcumin, which is a component of the medicinals 9, but also used on its own, which comes from a polyphenol, a bioflavonoid mixture from turmeric, has been shown to enhance ACE2 activity in the laboratory, both in test tubes and in animals, and also resveratrol, which is commercial resveratrol comes from Japanese knotweed for the most part, but resveratrol became famous because it's found in red grapes and was the alleged explanation for the French paradox. But it has anti-aging, anti-senolytic effects, and has been shown to enhance ACE2 activity in experimental animals. There also was a study in humans with acute COVID-19 that showed that high-dose resveratrol, by high doses, I mean 4,000 milligrams a day. That's like, you would get that much resveratrol from a barrel of wine, okay? A bottle of wine has 6 milligrams of resveratrol. This was 4,000 milligrams a day in pill form. It's doable, might be a little rough on the gut, but a week of that dose of resveratrol shortened the duration of symptoms, speeded recovery, and speeded viral clearance. Resveratrol had been shown previously to kill the MERS virus, which was a relative of SARS-CoV-2 and the SARS virus. And the effects of resveratrol and curcumin on ACE2 in experimental animals these are not just laboratory effects. These are effects that would be clinically meaningful in people if you understand what ACE2 is doing in the body. Prevention of aortic aneurysms, for example, improvement in heart function. I mean, these are really meaningful effects in live animals that can be translated into effects in humans. And so vitamin D, curcumin, and resveratrol are a very important part of my approach to treating acute COVID, preventing long COVID.
Thank you, Dr. Galland. I think we covered a lot of topics that not many clinicians would even think about. So thank you very much for this time. What advice would you provide to patients and healthcare providers who are treating long COVID patients?
Okay. First of all, COVID is not going away. It will be with us for a long time. And each time you get COVID, there is a risk of late complications. If you're a provider, I think it's important to recognize that long COVID is not only the symptoms that occur. There's an increased risk of heart attack, stroke, diabetes, high blood pressure, neurologic diseases, including Parkinson's. A whole range of things are aggravated by by having COVID-19. And we're seeing the incidence of these go up in the world as a result of the pandemic. And these increases are not a result of vaccination. That's been studied. They are they're a result of the infection. And some of them require actual infection, not just exposure to spike protein. Not all of them. I mean, it's a very complex area. Spike protein is very toxic. It is not the whole story. And you cannot base your whole treatment strategy on, well, we're just going to detoxify spike protein. The GI tract is very important. And if you can begin to understand the gut microbiome and those factors that influence it, you will become a better health practitioner over time. It's not easy. I mean, I've spent 40 years studying the microbiome, and I feel as if it's hard to keep up with the research.
Frankly. Indeed, it's very complex. But I think in the last 10 years, there have been more publications on the particular strains, and research has
Right. There are more publications doesn't make it easier to keep up.
Exactly. So as the message to the patients, would you advise to do any testing that people can do themselves without, proving that they have issues?
If you have a problem with fatigue, dizziness, even shortness of breath, there are 2 tests you can do on yourself at home that I think are worthwhile doing. One is what's called a 10-minute stand test. You need a pulse oximeter so you can check your pulse, heart rate, or you need to be able to check it, know how to check it, and have a watch with a second hand. And it would help if you have a blood pressure cuff or someone who can check your blood pressure. It's described in my document, and there's a link to a video that takes people through it. I didn't invent this test. I just was glad that it was out there. And you check your heart rate and blood pressure lying and minute by minute standing over 10 minutes, leaning against a wall. And I've explained ways in which it could be interpreted. Many, many people who are having difficulty after COVID have an autonomic nervous system dysfunction that is producing either POTS. Most of the time it's POTS. Sometimes it's what's called neurally mediated hypotension, in which the blood pressure drops. Sometimes the blood pressure actually goes up abnormally. There are some things that may help if you have this, and I explain them. There are dietary measures that may impact this, but it's something to take to your doctor, because with these numbers, maybe your doctor can respond. There are medications that can make a big difference.
Yes.
And let me just say, people can get totally well. I've had patients who were wheelchair bound when they first consulted me, who about a year and a half later were running 5K races. Okay, it can happen. Don't lose hope.
Yes, that is a great, hopeful message to the audience. So there are tests, there are people who understand the disease. So get in touch whoever needs help with Dr. Galland, who's very busy, or myself. I might get time for you. So if you found this video useful, please share it with your friends and family and help us raise awareness about long COVID. Thank you for tonight, and goodbye.